And of course, the main concern when patients develop AF is the significantly increased risk of stroke. So, Diraj, can you explain the mechanism and how quickly this stroke risk increases? And to help illustrate your answer, we have an echocardiogram of a patient recently diagnosed with AF.
Well, first of all, the atria perform a very important role. So in sinus rhythm, the atria contract. And not only does that contribute about 20% of the cardiac output, but also by its contractile function, it has a flushing effect on the blood in the left atrium. Once the left atrial appendage stops contracting in atrial fibrillation, as you can see in this example of a transesophageal echo image, blood stasis results. And blood stasis tends to concentrate mostly in the left atrial appendage, where also because the endothelial lining is very corrugated, unlike the smooth lining of the left atrium, the appendage itself has a very corrugated lining, and blood clots tend to form there. And what these images show is a very large thrombus originating in the apex of the left atrial appendage and making its way out all the way to the os. So yes, patients with atrial fibrillation are at increased risk of stroke. That risk does increase depending upon the presence of other risk factors. But the most important thing is that most thrombi, 90% of thrombi, in fact, form in the left atrial appendage.
Fantastic. So, Diraj, you mentioned that these clots can become very big, several centimeters in diameter. And when they break off and move into the systemic circulation, they usually go straight up the carotids and block proximally, usually, very major cerebrovascular arteries like the middle cerebral artery, causing huge areas of infarction. In fact, in the example here, we can see a huge left-sided MCA stroke, clear midline shift of the brain, simply catastrophic. So, and that is why the data clearly show that AF strokes are significantly more devastating than non-AF strokes, associated with a higher risk of mortality, morbidity, and significant disability. So, Diraj, let's now put this into context. What you can do in a cath lab for an AF patient, does it come close to the level of prognostic benefit of anticoagulation, or should anticoagulation always be our main priority in primary care?
Well, I think oral anticoagulation is the most important aspect of managing these patients. So if you look at the European Society of Cardiology guidelines for AF, published last year, they've made the management simple by giving it the ABC concept. Now, A stands for avoidance of stroke or anticoagulation. B is for better symptom control. And then C is for risk factor modification, etc. So the A is still the number one most important aspect, especially in primary care. So I would urge all my primary care colleagues to very actively screen patient atrial fibrillation. Once you have identified somebody has atrial fibrillation, then by and large, 95% of patients with atrial fibrillation would be eligible for oral anticoagulation based on the traditional CHAS-VAS score. So rather than thinking, oh, which patient is eligible for oral anticoagulation, you should almost switch it on its head and say which patients are not eligible for oral anticoagulation. Yes, oral anticoagulation by itself is one strategy, and there are several things that we can do in the cath lab, such as catheter ablation or left atrial appendage occlusion, which can complement the efforts of our primary care colleagues in managing these patients holistically. But I still say oral anticoagulation is the cornerstone for AF management.
Yeah, no, absolutely. And most international guidelines, including the ESC, very much advocate the use of DOACs as that first-line therapy. So really, total agreement with Diraj. Certainly in our clinical practice, very, very few patients that you would not be offering anticoagulation unless they're at truly very, very low risk with a CHADS-VASc of 0 or 1 if the patient's female.